Good evening. Welcome back. Thank you so much for being here with me on quite a few sessions. And this is one of the continuation things what we are doing. This time, what I thought is that I think last few sessions we started with the bipolar 2 disorder is a myth, and then few case studies I was trying to present to you. But this time the topic is slightly different. The title of the topic I put it as I, Dr. MSR psychiatrist, am depressed about depression. But actually I'll tell you, the last week was actually a little bit of a turbulent period. I was really wondering, last time I think some of you who are here, I told that we'll take up the topic of I'm depressed about depression. But then I put my name in that. A doctor and psychiatrist. Then I was wondering, why did I do that? And then do I have to do it really? Does it sound academic when I put my name in that like that? So there's a lot of dilly-dallying going on. The whole of week was and at some point of time, I even thought that, okay, right, I'll call Chintan and say that, can we change the title to just I'm depressed? But then at the end of the day, I thought, okay, let me go ahead with this. Let me share. See, I keep telling you all the time, when I talk about certain things, this is sharing of my perception, my concept, my views with all of you. It's literally, I keep telling many times, it's just a loud thinking of whatever I feel about mood disorders, about which I have a little bit more interest. But sometimes some of these things you may not agree with that, that's a different issue. You agree, don't agree, that's a totally different issue, but the similar way. So today, I thought, I sincerely feel about it. One thing I'm telling you very, very clearly, I didn't say it just for the sake of hyperbole. When I said that I am depressed about depression, I do mean it. Actually, I did a same topic, but this time I made it a slight change. I did a similar topic almost about 7-8 years back. I remember very clearly that was in Goa. I put the title as I am depressed about depression. This time I said that I am so and so feel depressed about. I feel the way the MDD is being managed. Why can't we do something better? Something more aggressive, something more organized, something more confident. I don't know whether I can ask this question. Some of you may feel that, no, how can you compare MDD with some other physical illness like that? And then, no, I don't think it's correct. But still I ask. As long as I consider psychiatry is a specialty, it's a medical specialty, I ask this question to all our psychiatrists. How many of us treat major depressive disorder with the same confidence a physician treats typhoid, tuberculosis? Of course, no, immediately the jumping will be there. No, there's a diagnostic, definite diagnosis there. Here we don't. I understand all those things, but I always say that diagnosis is a must. Provisional diagnosis, right, wrong diagnosis, we are all entitled to make wrong diagnosis, no problem. Diagnosis is prognosis, diagnosis indicates therapeutics. We have to make it. How many of us treat MDD, let us say need not be MDD with melancholia, recurrent depressive disorder, bipolar depression, psychotic depression, postpartum depression. How many of us treat them with the same kind of a confidence as we treat tuberculosis or typhoid. We don't seem to be. Then we have to understand why. What is the gap? What is the problem? That's what this today's topic is. I think before that I start my topic, I would request, I thought today I'll just put one or two questions for a kind of a poll. I think we'll put two questions. One is about, gap, treatment gap. Does it really exist, or it's only MS Reddy or somebody talking about it? Second thing is good prognosis, episode being curable. I think maybe we'll put the opinion.
Yeah, yes.
Let them answer that.
Yeah.
We will get the roughly an idea what the audience is thinking about it, and then I'll continue with that.
Yeah. So we are launching the first question. So the question is on your screen. I will request you to vote whether you agree that there is an 80% gap in the treatment of MDD. So you can choose one of the option, and then we will share the results with you and see.
Feel free, sir. Feel free. See, this actually it is 86%. I think, if I remember correct, National Institute of NIMHANS survey and 2016 has done. Feel free, if you don't feel that, a lot of times we don't agree with the statistics. If you don't feel, fine, there's no problem. But I want your opinion, because the whole lot of my topic is going to be dependent to a large extent on that.
Yeah, so the opinion is 60% have said yes, 20% no, and 20% don't.
Yes, right. 60%, sir, we are on the same page. The 20% of don't know, right? There's no problem, whichever way it comes. This 20% of no is something which I am looking at and see that whatever my talk, whatever we are discussing, whether it will convey something to see that there seem to be a possibility. Second question, Chintan.
Yeah, second question is launching. Do you agree the episodes of MDD, except in the chronic MDD, is it curable? You can vote one of the option.
This is one question where I'm going to see a little bit more of a tricky answers, because episode is curable in MDD. I'm really looking forward to the answers what you people are going to give, and a lot depends on that. A lot depends on what my colleague psychiatrists think about this particular episode of MDD. We're not looking at the long term, sir. Episode of MDD, is it curable? When I say curable, is the recovery possible?
Yeah, so 89% have voted for yes, and 9% for no, and 2% for don't.
Sir, you made my day. Whoever is there in the audience, you made my day. I'm extremely happy. Rather, I'll say that I would rather, no need for me to discuss about anything else. This actually, sincerely, I didn't expect this, because the whole lot of literature talks about it. That's what I think sometime back also I told. Kriplin told 100 years back, this is what it is. Why we are still talking about chronic disease? I understand that, but episode is curable. Which other psychiatric condition other than mood disorder you can talk about this is curable? Nothing else. That's what. Okay. Now I think I'll start my presentation today. Maybe, see, let's see that there are some questions actually which have come, but these questions immediately I may not be. There are 4 or 5 questions. One or two maybe I'll be answering in the during my presentation, but maybe I'll take up the questions at the end of it rather than breaking my presentation and see that. Let's see whether the flow is maintained. I don't know whether Dr. Ishwaran is there today in the group. There was one question, sir. I think you're right in pending that some 2-3 sessions back you asked the concept of mood stabilization. Why do you call it faulty when it is a normal pathology in bipolar disorders? And then how do you describe it? I did briefly touch on that, but I didn't answer completely, but I'll definitely try to the best of my knowledge to answer that. May not be in this session, sir, maybe sometime later. I'll definitely come back to you, sir.
Thank you, sir.
This is right. As I was telling you, I was little bit sheepy, a little bit what did I do? Why did I put my name here? But I think, right, let me see in the next 1 hour, how does the Now, like the presentation, and then what are the points where I can justify, no, like are there justifiable points to get depressed about? Let's see that. To start with, I thought I'll give you a glimpse of what Hippocrates, the father of medicine, was thinking about 2,700 years back exactly. 5th century BC, he did talk about melancholia. He did talk about depression, what we are talking about today. 2,700 years back, melancholia, right? Fear, depression that's prolonged. And he said this is due to excess black bile. Down. Disorder, this melancholia, distinguished from temperament and despondency, which occur in everyday life. 2,700 years back, Hippocrates described an entity called melancholia and clearly differentiated between disorder and temperament and despondency, which is normal sadness. That is, melancholia is separate from normal sadness. This is what he told 2.5 millennia before. And today, we psychiatrists are accused of saying that most of the times MDD is nothing but a normal sadness. You people make a diagnosis of MDD and then put them on dangerous antidepressant drugs. I'll come to it a bit later. And then he has beautifully talked about melancholia is due to excess black bile. Maybe today you and me are talking about, these are the 4 humors, one of the 4 humors talked about. Today we are talking about neurotransmitter, serotonin there. Was he meaning serotonin that time? I don't know. But 2 points. Number 1, he clearly differentiated melancholia, normal sadness, which was very, very definitely differentiable. No doubt about it. Second thing is, it is not because of all your vagaries of life, day-to-day stress and all. It's because of some hormones or neurotransmitters or humors in the body, which is because of that. Interestingly, the black bile is implicated in 2 disorders. One is actually melancholia, means actually black bile. One is, he said that depression is because of black bile. The second condition where he implicated black bile is cancer. Excess black bile produces melancholia. Consolidated, solidified black bile is tumors, and then I said cancer, which is for a long time held by Galen. So there's, I don't know, this is some link between somewhere between oncology and then psychiatry there, right? It's been there. It's been there. This is from the book Stanley Jackson, Melancholia and Depression from Hippocratic Times to Modern Times. This point I wanted to remember, 2,700 years back, he differentiated between these 2, and he said it's very clearly it's because of some disturbance in the body humors, right? Now, sir, this slide is, I want you to focus a little bit, like with more attention on this, where I'm going to talk about the morbidity of, you all know that, I'm just trying to repeat it. MDD is a common mental disorder. This is our NMHS figures, demand survey figures. Of all the mental morbidity, depression, one diagnosed alone occupies 25% of the space. Look at the magnitude of it. Of all the psychiatric morbidity, depression itself is 25%. This common mental disorder often becomes serious mental disorder, bipolar depression, psychotic depression, recurrent depressive disorders. And then another thing, a lot of times people say that it's a milder illness. It's a minimal symptoms. Even now I got a question, one of the questions, and this is that they come with a lot of vague symptoms like that. Then you call them MDD. No, sir, our diagnosis of MDD is here. 75% is moderate to severe. They are not mild. It's only 25% it is mild. So it's a common, it's a fairly severe, and it occupies 25% of space. Look at the magnitude of MDD among the psychiatric morbidity. Then second thing is that depression is a cause and consequence of non-communicable NMD, like diabetes, like hypertension, like coronary artery disease. Depression, the risk of diabetes goes up. The risk of MI goes up by like almost double or 100%. Once somebody has an MI, the risk of second attack goes up by another 100. Such a kind of, it's a cause of, one of the causes. Nobody says that depression is the cause. One of the cause for all, quite a lot of, it suppresses immunity. And also the consequences. People with diabetes, they have a higher risk of depression. People with MI, they'll go into more of like this one, depressions. People with muscular disorders, they go into depressions. And people with depression develop musculoskeletal disorders. So the burden of depressive disorder gets further deepened. Common disorder, 75% is a moderate severe, and this is linked to other physical illnesses in this. It can be a cause, one of the causative factors, and also consequence. Imagine the burden. And look at this. It's a survey, I think it's about 10 years back, survey 60 countries. Compared to greater decrement in perceived health, when there's a greater decrease in the perceived health, what happens is that most of the time there's a disability. Most of them, they are not functional. They will not work. There's a lot of doctor shopping. There's a lot of investigation being done. They feel they're not good. They're not well. Something is wrong. They keep on going round and round. That is a kind of a disability it produces compared to angina, arthritis, asthma, diabetes, cardiac, musculoskeletal, okay, respiratory, okay, endocrinal problem. Compared to all these problems, WHO survey shows MDD has got greater disability, perceived health. You know all these things. I'm only trying to compile that and see that what is the magnitude of the problem. Yeah, these are all high, DALYs and years lived with disability, years of life loss. No. And then this is a point I never get tired of putting it. See here, more than 40% is below the age of 20 years. If you look at here, comparison is with cardiac disorders, musculoskeletal, endocrinal. Okay, ask all these so-called disorders, onset is fourth decade and later. Depression onset is second decade. Look at that kind of a problem which, if it continues, if it is untreated, how long the person has to suffer. This becomes very, very important. And that's why the urgency to fill this gap. Right, it's actually 86%, not even 80%. Depressing treatment gap of 86%. 60% of you told that this 80% is correct. I think I am going to carry with you in my depression, you also into that depression. 86% of patients with MDD are not getting the correct treatment. Yes, then somebody may say, oh, this is one survey done in India. How can I say that it's different? I'm going to show another survey, sir, WHO survey, which is done all over the world. Some comments what they make also. I'm going to share them. This is actually surprising. Okay, you said it's developing countries. You say that there are no psychiatrists in India. Yes, we understand that. I'm going to discuss about it. But this is the burden. 3 crore population in India. 75% of them, almost 2.25 crores, is a moderate to severe. And the risk of diabetes, and this becomes worse. And then much more than other chronic, like in physical illnesses, starting at the age of 20, and this is fit. Don't you think, I'm smiling, but don't you think there's a reason for me to get depressed? Looking at this? Yeah, that's what I was looking at. Now, this is the picture. And now, as an average clinician working in my clinic and for the last 3-4 decades, what is my dilemma? I get a patient, I make a diagnosis of MDD. I start him on antidepressants and then maybe some counseling. I feel MDD is treatable, episode is curable. I was very happy when 90% of you told that episode is curable. I think we are all on the same page. So this is what a clinical psychiatrist thinks. MDD diagnosis is valid, it is treatable, antidepressants have effectiveness, and episode is curable. This is what my perception, my thinking, my experience in the last 3 decades, 4 decades, which I think is your experience also. Evidence-based medicine, RCTs have given us more than a dozen antidepressants, starting from imipramine to the latest Vortioxetine, Prozac, and all of it. At this point, let me tell you, evidence-based medicine that has given me these medicines, I salute them. RCTs, they have given me this. And at this point, let me also tell you, majority of these antidepressant drugs have come into the market with the R&D divisions conducted, RCTs conducted by pharma companies. Today we talk, like the next sentence is going to be something not very, complimenting them, but all these are given to me by the RCTs conducted by the pharma companies. I am extremely thankful to them. I am extremely thankful to the firm Eli Lilly, which has given me Prozac. No doubt about it. I openly say that, because without that, I would not have had any tools to treat depression. But the problem, next problem is that antidepressants are effective. That's what we are seeing, that effective, and then episode is. But the problem is that these RCTs say that all the antidepressants are equally effective. That is where my first clash comes here. I agree, but I don't agree in my clinical practice that all the antidepressants are equally effective. I cannot equate escitalopram with reboxetine or tineptine. I'm sorry, I'm mentioning some names. I cannot equate with that. So these ones, they are not equally effective. Then it's like this. Suppose an youngster comes and asks, all the antidepressants are equally effective. Why don't you start your next patient on tineptine? I'll say no. Then I'm not agreeing with this. So evidence-based medicine has given me very effective medicines, but when they say all the drugs are equally effective, I do not agree. But then explanation is RCTs are slightly artificial. You all know that. Ours is a clinical thing. We take suicidal risk and substance abuse, chronic and all those things. They exclude all those things. And this ulterior motive of whatever the pharma companies we talk about now, that is the reason why it happens. Fine, to a certain extent, satisfactory. I'm trying to find answers. Why they say equal effective, why it's not that? So because RCTs are conducted by the pharma companies or whatever it is, so excuse me. All right, I think there is some mishap there. So because there is something, the best thing is naturalistic studies, because there can be some of the problems, artificial milieu. So naturalistic studies are going to give us better kind of information. So the most important naturalistic study in psychiatry with regard to the major depressive disorder as on today, STAR-D, very large study, naturalistic, NIMH funded, no ulterior motives, nothing involved. But what has it done? Escitalopram, remission is only 1/3 of patients. Oh God, what do I do? Just now while comparing here, when I'm saying that they are not equally effective, I said escitalopram is very well effective and reboxetine is not effective, and then tineptine not effective. And the same escitalopram here, it's only 1/3 of patients. Is it worth talking about this role? No. Actually, when I gave the learning objects also, I didn't talk about SSRIs and then counseling. I said escitalopram and counseling for specific reason. The same escitalopram which is giving me curable episodes are curing. Here, STAR-D says that it's only in 1/3 of the patients. 2/3 of the patients do not improve. So the paradox here is that here, evidence-based medicine says that they're like an RCT say that they are equally effective. Naturalistic say that all the antidepressants used are not effective or equally not effective. Quite a few. Escitalopram, sertraline, bupropion, nortriptyline, I think phenylcepramine. I think the whole lot of things, all of them have only 1/3 of patient there is remission. And they include level 2. There's a cognitive therapy also. So what do you get from here? In my clinic, this is the experience. And then these people gave me good medicines, but they say equally effective, which I do not agree with, doesn't seem to be. And when I come here, this says that your antidepressant is not working at all. It's only in 1/3. How do I correlate this to what I'm finding here and what I'm finding here? This is the dilemmas. This is the dilemma what I have. How do I answer an youngster? How do I clarify myself about what are the findings? Now I'm struggling with these two. Now something else has come. Obviously, antidepressants are nothing but placebos with side effects at Irvin Kirsch. Actually, if you look at this, citalopram is effective in remission only 1/3 of patients. It's almost like placebo. I don't think he made any exaggeration in this, but such a drastic statement. It's side effects. Placebo doesn't have side effects. Citalopram, whatever the side effects it does. So when he made this statement, you can easily link these two. And then Nasir Gami says that antidepressants are not antidepressants. It's an excellent article in bipolar disorders. And then what? Nasir Kami is one fellow I have a great respect, and then I think sometime back also I told that he is an excellent research worker, but maybe some of the ideas we may not be agreeing, or he has got his own perceptible thing, different thing. So this statement, placebo, does it sort of go in concurrence with this? Antidepressants are not, and is it in concurrence with this when there is only 1/3 of patients responding? How do you call a drug as a drug? It's almost equal to placebo, right? So these two statements are rubbing salt into my confusion here into this. Now, one more thing has come, even the diagnosis question. MDD is a political compromise grafted onto science, DSM-3. Diagnosis itself is a lot of heterogeneity. It's not a uniform diagnosis. There's a lot of problem. It's not a scientific diagnosis. It's a political compromise. So now I'll just run through. In the clinic, this is what we all see. But then we don't see this. And then this is not like, disaster. Only 1/3 being. How do I? Then somebody says that this is this and this is this. And diagnosis itself is question. These are the dilemmas. When I asked you, are you confidently treating MDD as somebody treats typhoid? Typhoid, nobody says it's a compromise. Chloramphenicol, nobody says it's only 1/3 of patients. That's a difference. But how do we manage this? Is it correct? Let us see whether we can answer some other questions. I think, again, this is broadly, this is my concept about, like all of you know that when you treat a patient, there's a response, remission, relapse, recovery, and recurrence, right? Let us say that this is the state of euthymia. This is depression, right? Somebody had an episode of depression. This is depression, right? All of us know. This everything what you know. I'm trying to spend a little bit more time on this because this is depression. Patient is in a state of depression, MDD, episode of MDD. Suppose you leave MDD without any treatment. You leave him. You'll reach euthymia here. He'll recover. You'll recover, sir. There's no doubt about it. Natural course of mood disorders is total recovery and then episodic. So if you leave an episode of depression, MDD, without any treatment, at some point of time he has to come back to this euthymic state. There's no doubt about it, and I think we have seen. So when you compare an antidepressant with placebo, if you compare it here, antidepressant is more effective. But at this point of time, if you compare antidepressant placebo, both are equally effective because natural course has done its job. Our job is, this is natural course. This is what is called remission and recovery. See here, this is, I think you all know that this is MDD. Patient has come to euthymia, HAM-D is less than 7. This is called remission. Then somebody asked me, why do you have to wait for 8 to 12 weeks after HAM-D has come to less than 7 and patient is euthymic? Then why can't you pronounce it here itself as recovery? And then, sir, I think it's to be more sure, to be more definite. Sir, you are treating, once again, you are treating a diabetic patient. One day blood sugar is 100. You are not happy. You have to see consistently, like 100 around that blood sugars. One day fever being normal is not enough. You have to see consistently, normal temperature for a few days. Then only you say recovery. In the same context, it's also been taken here. Nothing more than that. This is, some people say 8 weeks, some people say 12 weeks. It's perfect. What is my job? As I told, depression, if you leave it, is going to recover. You don't touch it, you're going to recover. No doubt about it. I'm not talking about dysthymia. I'm not talking about chronic MDD. I'm talking about melancholia, psychotic depression, postpartum, seasonal, recurrent depression, bipolar depression. I'm talking about. They have to recover, they recover. But our job is, can we shorten this? Facilitating the natural course, thereby minimizing the morbidity and preventing mortality. So instead of going for the 6 months or 8 months, can I make him reach the euthymic state in a period of 2 months or 3 weeks? This is what is my job. Whether I do with antidepressants, whether I do with CBT or ECT or RTMS, whatever it is, this is my job. This period, I have to shorten it. This period of morbidity, this period of risk for suicide, this period of causing for diabetes and MIs and all those things, this is the period which gives a lot of discomfort and disability to the patient and make him functionally invalid. So I have to shorten it. This shortening is something which I do with the entire, whatever the technique you do, but this is my job. But if you leave it, he's going to recover. This point why I'm saying is very important is, when it comes to, that's what my feeling is. When it comes to depression, sometimes all the antidepressants are equally effective. So you give the patient escitalopram, he recovers here. You give the patient tyneptine, he also recovers. At this point, escitalopram and tyneptine are equal. Escitalopram and then reboxetine are equal. Escitalopram and lithium are equal when it comes to bipolar depression. Escitalopram and quetiapine are equal when it comes to this point, because natural course has already come. So a lot of patients, a lot of people ask me, Dr. Reddy, you're talking about quetiapine is not a good antidepressant in bipolar depression. Lithium, how is it good? But they work for me. Valproate work for me. I did. At this point, all those things work, sir, but I want it to be here. That is why I am here for. That is why my qualified psychiatrist or medical person is here to cut short this. This is a very, very important slide for me. Leave it. It's going at this point, placebo, lithium, antidepressant, everything, unless I disturb this, unless I create more disturbance, which we are doing sometimes. I'll come to it later. Leave it. So this is an important thing. At this point, every drug, everything in the universe is equal when it comes to the management of it. But at this point is something what we have to seek is minimize the morbidity and preventing mortality. So most important thing, I see the gap here, right? How did you come to this conclusion, right? Look at this simple table. This is the Northwest Wales asylum story. This is one of the asylums in UK. Two periods are compared. This is the thing which I've taken from Yatham's book. 1875 to 1925, 1994 to 2005. This is the 50 years and this is about 10 years. This is the period, all of you know that. Forget about antidepressant. I don't think even ECT was available. Whoever was sick, he was put in the so-called asylum. Let's not worry about this. Average length of hospital stay for one episode. First, let us read it. Almost all patients went home well. Sir, 1875, 1890, when there was no intervention available, even psychoanalysis was not available, almost all patients went home well. That is why I said that natural course of recovery is there in these mood disorders. But they went home well after 6 months, sir. Here, in this 1995, 2000, they are going home well after 1 month. It's absolutely phenomenal contribution of pharmacotherapy in the management of mood disorders. Here they went well. Here also they went well. Here they went well after 6 months. Here they went well after 1 month. This is what I'm saying, that here they went well, but after 6 months. Here they went well after 1 month. This is the difference. This is the difference what we have to see. This is what pharmacotherapy has done. I think 1920, around that period, Kraepelin has brought out his first book classifying manic depressive psychosis and dementia precox. He was observing these patients, a group of patients. They're going well. That is where he said that good prognosis. That's why he said that episodic. That's why he said that recovery is the rule. Based on observing these patients who are the other group of patients, they were never going home. They were never going home. They were staying in the hospital continuously like that. We have become dementia precox. And these patients have become manic depressive psychosis. Now do you understand? This is what we need to shorten this. We need to bend the curve. We need to cut short the duration of the disability. That is what our job is. And the example is this, based on this. Look at the periods. This is what the great contribution of the modern science in psychiatry. This is what absolutely fantastic. That's what I'm talking to you about. Now, this is the slide which triggered my first presentation as I am depressed about depression. 1980, Martin Keller et al. Clearly said that documented gross undertreatment of mood disorders. Quarter century later, this additional years are mine. Actually, this is a large gap between high prevalence of depression and delayed and infrequent use of antidepressants. This is quarter century later. Look at the, statements. High prevalence of depression. I think what we are talking about is 2.5 prevalence. Delayed antidepressant treatment. Infrequent use. Why? They are antidepressants. By 2005, all our SSRIs are available in the market. All almost, at least fluoxetine, sertraline are available. Escitalopram, I don't remember. It's available. Why they were not using, delaying? Why they were infrequent using? Because psychiatrists were not very convinced about the diagnostic entity of MDD. Psychiatrists were not convinced about the efficacy of antidepressants. They are not effective. Psychopharmacological Calvinism, medical ethicism. You should not be giving drugs to improve somebody's mood. The whole lot of psychoanalysis. These are the reasons. Here, DSM-3 broke psychoanalytical thing. That's the reason. This is my explanation, sir. I don't know if somebody has got some explanation. There is high prevalence, but there are antidepressants available. But why they don't? Tricyclics, I understand there are a lot of side effects. I also. But it is SSRIs. Why infrequently are you using? Why are you delaying? There must be some reason. My understanding is that Calvinism, not having the kind of a belief on the drugs that time. Come 2012, depression, global crisis. This is WHO. The NMHC Indian 86%, more than 50%, they don't give a definite figure, do not receive adequate treatment, not just in developing countries. This is what I am worried. India, you all can have one answer. Dr. Reddy, you said 2.5%. There are 3 crore patients with depression right now. There are only 9,000 psychiatrists. How do you think they can treat? There's a gap. Yes, sir. But what about developing country like US? So that's why they said not just in developing countries. And this is the phrase, this sentence is something which bothered me for months and years. Like, what is this? What is this? And then why should WHO clearly say that it's not always due to lack of resources? We understand lack of resources like India. But they said it's not always due to, but there is something else. What is that something else? Today, if you look at the same figures, America, United States of America has about 1 crore of depressed patients with MDD. You know what is the number of psychiatrists in USA? I think all of you know, more than a lakh. Number of psychologists registered, more than a lakh. Number of psychiatric social workers, more than abundant resources. But he says not always, even though resources are available, still do not receive adequate treatment. This is what triggered me. I said, then what are the reasons? Why? You have the diagnosis, you have the safe antidepressant, the diagnosis is not, and then you developed countries, and then America spends $8,000 per capita on health expenditure. Why? This is the first time I made a presentation. I'm depressed about depression. 2017, again, WHO comes out with like depression. Let's talk. I said that let us talk now. Let us treat. That's going to. This is my addition. This is WHO's. We have to treat. No talking. Okay, talking is the first step. This is the first time. 2012, I presented this talk because I was not able to see this. Then I was not able to understand why. Then this is bothered. This is completely baffling me. Developed countries, not due to lack of, so why it's not being treated, why there is a gap more than 50%, a simple disorders like 50%. First slide, if you remember, the disability, the cause and consequence, the suicidality, all those things, why? Let's see. This is maybe some of you who are now like attended, maybe I think recently also I showed you. This is one of my very favorite slides. This is something which I borrowed from Thomas Insel, who was an NIMH director. I attended one of his lectures and he presented this. This is a wonderful, of course, some of you may say that suicide is not completely, need not be due to medical reasons. There are farmers' suicide, there are dowry suicide, there are psychosocial factors and all things. Absolutely, I agree with all those things. But if there is one specialist, medical specialist who has got every right to talk about suicide, that is psychiatrist. So we have to hold some responsibility also. This slide is a good slide. See, percentage of peak. He compared 3 decades, 1965 to 1995. This is 1965. This is 1995. Right? 30 years. What are the changes which has happened in the medical conditions? In 1965, broadly, if you look at leukemias, heart diseases, AIDS, strokes, all those things, let us take it as 100% morbidity. No, give it a ballpark figure. So in 65, if the morbidity and mortality for the ALL is 100%, now 95, it has come to how much, sir? It's at 15%. Significant reduction, bend the curve. They bend the curve. Today, ALL is curable. Patients live the rest of their life without any. So it's bent. Then cardiac. People used to die of MIs. Now the cardiac death is much less after CABG. Very effectively. So from 100, it has come to about 30, 35. Bend the curve. Here the bend the curve. Here the bend the curve. Actually, this should have been here. Maybe that 50 years back, it was almost like, fatal. Now everybody is alive. A stroke, right? It was 100. Now it's around 75. Some, like the golden hour they talk about, like some those things they talk about. But when it comes to suicides, so this is not my slide. This is Thomas Inch's slide, which he has presented in a American Psychiatric Association meeting. This is what he presented, and he said that 65, 95, we don't seem to have done any kind of a bending the curve with respect to suicides. As a student, my professor told me 15% of patients with mood disorders commit suicide. And today I tell my students after 4 decades, 15% of my patients with MDD commit suicide. What are we doing? I don't say that we have not done anything, but this is an excellent slide showing that somewhere something is not happening right when it comes to the management of prevention of suicides. And suicides are most commonly, you may say impulsivity and other things, most commonly secondary to depression. That's when say that depression is not being treated effectively. And that is why, once again, that 80% gap seems to be true. Otherwise, this curve also should have been bent somewhere at least here, but that doesn't seem to be. So this is one. Next, briefly, I'll run through this. All of us know, all over the world, the ratio of depression is twice more in women compared to men. All right, if not to 1.5. This is not like female. You see this all over the world. Male, see, comparatively, in the general population, for every man who gets depressed, 2 women get depressed. That's the risk. Whatever 100 factors, whatever it is, we don't know yet. But I feel that because the topic has come, this is my feeling. The secret for the mood disorders, especially the neurobiological secret for the MDD, lies in female hormonal system irregularities. There is no doubt about it. Looking at premenstrual tension, looking at the postpartum depression, looking at the increased numbers, but that's anyway a different point. So the females have high numbers of risk of depression. So obviously, when you say that 15% of depressives commit suicide, obviously it should be more in case of females. The death with suicide should be more in case of females. But see here, suddenly reverse. All over the world, I don't know how it is. I'm always keep asking the questions, except maybe I don't know what it is in low and middle income Western Pacific. And the only country I saw recently, and I was looking at the figures, is China. It's only in China the suicide rates with females is slightly higher than compared to men, but otherwise, depressions are more common in women. Suicide deaths are more common in men. How do we explain this? What is the reason? For quite a long time, this is the problem for me. I'm not able to get into some kind of an answer. I don't know whether this is, I feel that this may be one of the answers which I can talk about. This is one of the long-term studies for 30 years follow-up of the major depressive disorder. Here also see that when they followed up for 30 years, average, it's only 40% of the people are getting treated. 60% of patients with MDD are not taking the treatment, whatever may be the reasons. This is the most important point for me. Women had triple the treatment prevalence of men. For every 100 women who are suffering from MDD, 23.8 went for treatment. For every 100 men who are suffering from MDD, only 7.4% went for treatment, whatever may be the reasons. Does it explain why there's more suicidal deaths in men? I don't know. I thought it could be one explanation. There can be some other explanations, but I felt that this is a less number of people are getting, men are getting affected, but they don't get the treatment. When they don't get the treatment, the risk of suicide is high. Obviously, this is one of that. That is what I feel. Can this be considered as a powerful and significant indicator of treatment benefit? Women are going for the treatment and they are saved of that suicidal death. Men are not going for the treatment. Whatever the reason, I think most of the time we know the reason. Men are supposed to be very brave. You can't cry. Depression is a sign of weakness. All nonsense. Whatever maybe. But this figure, why men have more suicidal deaths when women have more suicidal numbers? Simply because they do not, the treatment in men is much, much less. So if that can do this kind of wonders in that, I think you can understand proper treatment of MDD, how much benefit it can give. That is going to be that's why I thought I'll put the slide. And this is a proof, as I said, that indicator of why should we treat MDD? Why should we effectively treat? Why should we aggressively treat? Prevent suicide, which is going to be the most important thing, which is the statistics are showing here, right? And then broadly, next few slides I'm going to show. I started with Hippocrates thing, and then I showed you that what is the burden of MDD, and then 86% gap. And then I came to my clinicians in my practice dilemma. My patients are improving. Study says only 30%. My clinic 70%, 80% are improving. I make a diagnosis of MDD. They say antidepressants are placebos and all. I'm getting confused. And then how do I come to some kind of an understanding for this? And then, right, again in the same, women have more depressions and then men more come to say. So I'm trying to see whether I can understand the process one after the other. 2 points. Under treatment of MDD, overdiagnosis and over-treatment of bipolar disorder seem to be one of the very common things. Now, the diagnosis itself is questioned here. Typhoid is not questioned, tuberculosis is not questioned, but MDD is a political compromise. So that itself is half the confidence is gone. I think I was telling you, depression may not be an illness at all. Often it can be a normal reaction to abnormal situations. Hippocrates, 2,700 years back, he said that there is something like a normal sadness, there is something like melancholia. Here somebody comments saying that depression is not at all an illness. All your major depressive disorders are nothing but normal reaction to abnormal. Second thing is depression is not caused by chemical imbalance. That man told that it's because of excess of black bile. So these two statements support this. And these are not just some statements, sir. And right, I'll come to it. So this is what, if the perception is that it's just a normal, you're unnecessarily branding them as MDD. There's nothing like chemicals and serotonin, this nonsense and all those things. There's nothing like medication. Obviously, it goes under treatment. Read this, sir. I made the statement some time back when somebody said antidepressants are not antidepressants. But I say that the medicines are working, man. Yeah, then the answer is powdered stone, frog sperm. So according to this statement, your antidepressant escitalopram is almost equal to maybe dolphin's genitalia, or frog's sperm or powdered stone, and bleeding with leeches. It worked. So this also worked. That's it. Simple. Placebos with side effects. Then what is the confidence of an average psychiatrist on the antidepressant? And study, I showed you, only 1/3, nothing more than that. And this is another statement. Look at this. Large portion of non-bipolar is neurotic and is best treated with psychotherapy. Pause for a moment. MDD is a political diagnosis. Antidepressants are not better than powdered stone or frog sperm. And then study says it's only 1/3. And then one more statement. Only bipolar depression is a biological depression. Rest of it is all neurotic. All your melancholia, psychotic, and all those things are treated with psychotherapy. Where? How can somebody prescribe antidepressants? Antidepressants increase suicidality. FDA black box warning. See, like this is a fact maybe. Sir, what is the ridiculousness of putting it on the web page and then continuing it like that for decades? This has happened. First came in 1990. They put a commission that is ruled out. It's only increase in suicidality, but nothing more than that. And it's continuing. Patient is suicidal with depression and you prescribe antidepressant, it's supposed to increase. Suppose any patient who goes and Googles how it is going to look, see that. I am not just saying for the sake of it. I had one senior doctor, very senior surgeon, who was in a significant depression. He came to me. I started him, or I explained to him, I respect him a lot. Spent a lot of time. Told, sir, this is what is going. Already he's suffering with that for last 2-3 months. Put him on 5 milligrams of Escitalopram. The next day morning, he is one of those persons, already doctor, he goes and reads and he has not of, he's a surgeon. Next day morning, he calls me, Dr. Reddy, you have given me the Escitalopram last night. Today morning, I am feeling more suicidal. A senior colleague, he says that maybe is it because of your drug? He asked me. I know for 200% that he went and Googled and then he saw this and then he was like stuck to that and he was morbidly worried. And then he said that, no, I don't want to take. I may be talking about one exceptional case, but this is a case which happened. Then I don't know how to convince him. I don't know how to talk about it. And then I tried to explain and all, but he was not. Then he stopped. Sir, I'll tell you, the next 4 months or 5 months, he suffered with the depression like anything. He didn't come back to me. I thought maybe natural course he would have improved, or he went to somebody after 4 months or 5 months, he comes in a much more severe depression, says that I'm still not well, do something. I am exaggerating, I know. But this is what people see that. Like, this kind of cases may be so many. So is it one of the reasons why people are not taking? Right, there's so many things. Why people are not prescribing and they're not taking. The confidence in both the diagnosis and antidepressants are shattered with this. This particular slide, if anybody sees, the whole concept of major depressive disorder, antidepressant treatment is a joke. This is this, nothing much of difference. And this your so-called best naturalistic study showed only 1/3. I cannot open my mouth. I have to shut my mouth if somebody says this. And this is a possibility. And this is a fact which FDA put it on the. Wait, how do I think a lot of us are brave hearts. That's why we are continuing to prescribe and because we see the result. All the barriers to diagnosis and treatment are barriers against recovery. This is the problem. So this slide, if you see, now we understand why MDD can be undertreated. Diagnosis doubtful. This fact. So sad. So really sad. Now, let's go to the study. 1/3. I just want to spend only half a minute on this. I think most of you know it, but if somebody who has not gone into the details, I just want to tell you, sir, one thing. This is the final conclusion of study. Despite the pervasive belief regarding effectiveness, all you physicians and society are believing in the effectiveness of AD and cognitive therapy, we show that they fail to result in. This is the conclusion of study. You people in the lay public and physicians are believing that antidepressants and cognitive therapy are working, but my study has failed to result in this. What? Now, like you may say something, I may say something. You're a senior person, you're experienced in the clinical practice, but imagine a first year DPM student coming to that, he has to believe it. Naturalistic study has to believe it. So he believes that identity may not be that effective. He may not say totally rule out, but he may not be. Now, come to the point, sir. There are about 4,200 patients, recruit into that. This 360 and 3,600 plus this. So at every stage, there is 33%. This is the remission rate. This is a stage 1, this number, stage 2, this number, stage 3, this number, stage 4, this number. This is a 1-year study. They started with 4,300 patients. They ended with 123 patients. At every stage, 1,000 patients drop out, 600 patients drop out, 200 patients. Where did they go? What is the reason why they dropped out? They improved. We need an answer for this. Study does not give any answer for this. They said that they dropped out. Attrition rate is high. But why the attrition rate is high? With this kind of an attrition rate being so high, can you come to this kind of a conclusion? That's what my question is. Your 4,300 patients has come to 123 in a matter of 1 year. And you don't give any explanation where there's any suicide, where there's a switch, where they dropped out, where they improved. Every stage, there thousands are going out. And this is the conclusion. Fine. That's what they... finally, that's what the finding they told about is. But now if I tell the postgraduate, look, this is the thing, he will feel that, yeah, there seems to be something here. So you have to take it with a little bit of a pinch of salt. That's why I showed it here. Attrition from AD treatment is substantial public health. This is very correct. Antidepressant treatment, there's so much of attrition. Public health concern, that's a problem. And now, this even otherwise it's a problem. So suppose, just like let's look at, suppose you prescribe antidepressants to a patient, ask him to take, saying that it's going to be effective, your depression is going to come down, this and all this. He goes and Googles, everything is on the Google. He sees the study, this thing, and he sees this. And he will be another patient who is going to drop out from your treatment. Because anyway, they are working only 1/3, 30% only. Yeah, why should I take it? No. Worsens this. Everybody knows about this. And this is one thing, when a layman, when a public person asks us about this, I'm not going to tell everybody all these things. We cannot. What is this, Dr. Escitalopram works only in 1/3 of patients. How do I answer them? Now everybody is smart, everybody Googles. How do I answer them? But no, that is a fact. Now, this one I'll quickly run through, because now, like MDD, political compromise, but the construct validity, these are the 5 factors which you need to know. Symptoms, response, treatment, course, heredity. Symptom cluster, DSM-5 describes. Respond to treatment. I think it's clearly very given that the response treatment is very good, and then uniformly they recover. Course of illness, episodic. And hereditary factors, we all know that depression, hereditary, and family history is very important. So pathology, anyway, no psychiatric disorder comes to this. So these 4 factors, it reasonably satisfies. So because of that, in spite of lot of plurality, this underlying singularity is the reason, that is where it has come. Neutral with respect to one of the great things about MDD is it is neutral to the etiological factor. Some of the youngsters may not be very much knowledge of it, but we all know that endogenous, exogenous. Endogenous is biological, exogenous is external factors. You are supposed to give antidepressants only to endogenous. No antidepressants for exogenous. We don't know how many people with that so-called exogenous are not getting the benefit of antidepressant. That is where this is neutral to that. And this is something which I see that the greatest utility benefit of MDD, whatever may be the etiological factor, it seems to help this. That is what is very, very important with this. With these 2 factors, I consider MDD as reasonably valid. Now, there is a heterogeneous group. According to DSM-5, you can make 250 different types of MDD, but it's okay. But there are certain things which symptom cluster is the same. Course, responded, this you are satisfied. So absolutely. And then if you look at this, I think you remember, if except for bipolar depression, rest of everything is neurotic and treated with psychotherapy. MDD does not differentiate between bipolar depression, unipolar depression, depression, melancholy, and all. It's a common criteria. That's a disaster there. So to avoid that, DSM-3 is the first attempt to break away from psychoanalysis. That's where the MDD has come. Here, I think one of the persons has asked a question. See, a lot of times, the current episode, a patient walks into your clinic, talks about, doctor, I don't feel good. I'm feeling a little bit worried, sad. Sometimes I don't sleep well. And then I don't feel like eating. And then I lost some interest in work. But at the same time, I'm not depressed or anything like that. I have a headache. I have a back pain. The cluster of symptoms, it doesn't fit into any other so-called organic condition. Everything has been done in normal, but there are some hints about depression diagnosis, possibly MDD, but you are not sure. How do we deal with it? There's quite a lot of patients, not a few. Sir, How many times you see a definite clinical presentation? How many times people diagnose diabetes with polyuria, polydipsia? How many times people diagnose hypertension? There are other things. They have the diagnostic test. They do that. We don't have it. So non-specific. Suppose a patient like this has come. Rest of all the investigations are normal. Possibly MDD. Possibly major depression. Then how do I confirm? I don't have a diagnostic test, but I depend to large extent on these two factors. One is family history, past episode. For me, these are biomarkers. I'll give you the same example, very vague clinical picture, possibility of MDD. Then I look into the family history. If there's a family history of depression, either bipolar, alcohol dependence, especially if it is a dipsomania episodic type, if there is suicide, if there is some episodic illness vaguely, if there's a history of, this picture is vague, but if there is something which I find here, I'll treat him. I may put a query MDD, but I'll treat him more aggressively as MDD. This is very, very important. Then second thing is past episodes. Suppose he had got 2 episodes in the past, or natural, he recovered. Doctor, he had 3 years back 1 episode, but he became all right doctor in about 2 months time. And he responded very well to this particular drug. Or he had 1 episode that time, 1 episode after 4 years, and 1 episode now. In between, he was functioning excellent doctor. I took it as episodic illness. Functional status is good. So these two factors are clinical biomarkers for me, because cross-sectional presentation in most of the times in our diagnosis does not come with a textbook description. It looks vague. So when it is vague, otherwise we send for a lab investigation, we send for a CT scan, we send for an ultrasound, we send for a pathology thing. But here we don't have it. That is why we are facing the trouble. These two are very important. Whatever vague it is, if I find the family, father had a depressive illness, he recovered, or one of the family members committed suicide, then I will treat this as a definite diagnosis, even though cross-sectionally it is not satisfying all your DSM-5 criteria. So these two are extremely important things for me in coming to diagnosis. That is what I say, that these two, spend any amount of time, because it's worth it. Because clinical presentation being vague, your diagnosis query, you are doubtful about it, you don't treat the patient effectively, aggressively, definitely. You start antidepressant, maybe. You start some counseling, let us see. 10 milligrams, okay, it's that's where a lot of times that residual symptoms and treatment does not go properly. But if any of these things give a clue, like your diagnostic test, you go out, you suppose let me see, this is a non-specific presentation. It doesn't fit into the DSM-5 criteria. This man came with just 1 week. It doesn't fit into the criteria. Let me see that some vague symptoms. Suppose I find one of the first degree relative committed suicide. Another first degree relative had a definite episodic depression. I don't hesitate to straight away go ahead and then give ECT to this patient. Don't hesitate, because these are the important biomarkers for me. These are very, very important things, because I don't have the luxury of diagnostic tests. So next, that is where it's important, these two, what I talk about. Here, I'll just quickly run through what are all the ways depression can present. Sir, no, I'm not saying that this is MDD, possibilities we can consider. Can we consider, sir, here? Possibility of MDD query, right? Unlikely to have cancer, possibility. These are all 2 months only, recently only 3 weeks. All the time. Somebody say fibromyalgia, but right, possibility of depression, MDD. This may be there, but to the extent slashing the wrist, is it a vulnerable patient? No reason he's become like that. We don't know. We think about maybe love affair, this, not possibility of depression, right? Then this, all this, starting from the age of 65, 70s to the age of 10, depression can manifest any of these things. But these are all vague symptoms. These are not definite. But in this kind of vague symptoms, if you find a family history, which is very, very definite, if you find a past episode very definite, these can be treated very effectively. That is what the point of my putting up this slide. Right, I'll come to this point. I don't know. Of late, this has become a kind of a bugbear for me. Over-diagnosis and over-treatment concept. It's a lot of, it gets into that nouns like, almost like. This is one of the major reasons that's playing havoc, I feel, in psychiatry right now, especially mood disorders. Mood disorders are good prognosis disorders. They treat them well, they recover. Episode is recoverable, recurrence is there, but complete recovery, symptomatic recovery, functional recovery, all those things they talk about, this is completely muddling it. BD1 is prevalence is 0.4. Spectrum, everything put together at 1.6. So if you look at this 300% increase, BD1 is this. If you look at all 300% increase in diagnosis, if you look at all bipolar 2s and then bipolar spectrums and soft bipolars, and it's a huge increase. I feel this, all this is MDD is being wrongly over-diagnosed. I don't say everything, but possibly. I'm worried. I'm worried because of reasons, right? What is a short-term worry? Let us simply say that this is spectrum. Somebody diagnosed a simple case of MDD as a bipolar disorder, bipolar spectrum disorder. Immediate worry is for me. Step BD says that antidepressants are not effective in bipolar depression. Fine. Its efficacy is doubtful. So this is MDD but diagnosed as bipolar spectrum. So step BD said antidepressants are not effective, so you're not going to start. But I have been asking this question hundreds of times. Step BD, the two antidepressants studied are bupropion and paroxetine. If I use a little bit of a kind of a language, bupropion. Who asked them to select bupropion? Bupropion, how many of you use as an effective antidepressant? I doubt. And then they use this is not effective, and they generalize that antidepressants are not effective, right? Every time I have been asking why these are not studied in the management of this, what is the evidence that these are not effective? Okay, later it has come. And then they say that don't prescribe all this, prescribe lithium, prescribe quetiapine, prescribe OFC. Yes, somebody says that I prescribe lithium, I prescribe quetiapine, it's working, that bipolar depression has improved. I take them as a natural course, which is saying that that is how improve. But anyway, I am also stretching it a little bit, I understand. So short term, I will not give antidepressant, but I'll give one of these drugs. But because of the natural course of recovery, the man has recovered. No problem. He recovered. At least I am happy with that. But I am worried about the long-term effects. Concern. This is the danger here. This is the biggest danger I'm always worried about, because here at least I don't give, I give something else, they recover. Okay. Because here, if I, MDD, wrongly diagnosed BD spectrum, even if I think of antidepressant, my God, this is going to worsen the long-term course. Cycle acceleration. Acid, I told you last time, tardive dysphoria. Antidepressant induce chronic irritable dysphoria, tardive dysphoria. Basically, most of us doctors are good fellows. They're good human beings. I said that as doctors, I think if you compare with all the professions, medical profession, in spite of whatever the worst thing I am, I'm a much more decent and then compassionate human being I am. Short term, it's okay, right, to improve. But when I keep a drug, according to the literature, theory, textbooks and all things, if I start an antidepressant for somebody who is a bipolar disorder, he's going to have more cycles. He's going to have tardive dysphoria. I'm going to, what is this man? Acid, chronic irritable dysphoria. I'm going to be producing all these things. My antidepressant prescription is the reason why this patient is going to suffer from all those things. So I'll think 10 times or I will not prescribe. This is what I'm more worried about. This is what I think is damage is being done to the management of it. Do no harm, right? No, like all these things is a harm. You think it's being produced by giving antidepressant, so do no harm. I very strictly follow Hippocrates. But in the process, are we doing greater harm to MDD, which is actually MDD, which is wrongly diagnosed as bipolar spectrum? I don't know. I don't know. But that is what. If you say that bipolar disorder, antidepressants can be given, they are useful, they can be given routinely, this point does not arise at all. I will not have any discussion at all. But because of these things, it's always worry, because We don't want to be the cause for worsening of my patient's cycles and then tardive dysphoria. So I will not treat MDD. So if it comes to the MDD, if it is MDD wrongly diagnosed, it's a clinical disaster. If it is bipolar disorder, fine, I agree with that. There's no point. But I feel that this is over treatment. And this so-called, this one, lifelong medicines, which is good. Now, right, at this point, I'll just slightly, now I can show the case what I've seen. I said MDD is natural course is recovery. Whatever you do, patient has to recover from the episode. I showed you that graph also. But then why are you cribbing all those things? Anyway, they're going to recover. Whether you give this, they're going to recover. What is your problem? What is the disaster you're talking about? You know what is the disaster I'm talking about? We are hampering the natural course of recovery. We, with our intervention of whatever pharmacotherapy, we are disturbing the natural course. We are destroying the natural course of it and then prolonging that. I'll show you clearly. I think last week only I discussed my case. My case, what I have done. This patient, simple. She came to me with a diagnosis of bipolar disorder. That's where the whole problem has. See, like here, November 2014, patient came with depression, whatever, like just a month before she came, patient was on Escitalopram. By January 2015, that is in a 2 months period, 90% improvement, patient is on Escitalopram, right? And again, there's a relapse of depression, October, whatever lithium or it is, Escitalopram was there, January 2016, that's again 3 months. Here in 2 months, in 3 months, episode of depression, complete recovery, 90%, 90%. I think last time I discussed. Now, September 2016, she presented with irritable. Looking back, this is a depression with irritable presentation. I made a diagnosis of query bipolar mania. And then here, right, here definitely it's not there. It took more than at least, like September, no? This is January. At least 4 months, she's still depressed. 2 months, 3 months, Escitalopram, she recovered. Whether it is natural course or whatever it is. Here you see this. 2011, that's 17 November, she presented with another episode. And they know what is the recovery. When did it happen? 90%. June 2018, that is 8 months. This patient who recovered from a depressive episode in 2 months here, 2 months here, when it came to this, she took almost 7 to 8 months to recover from the depression. What is the reason? Reason is me. I made a wrong diagnosis of bipolar disorder possibility and I started the patient on risperidone. I disturbed her natural course of it, which continued until I started Escitalopram. This thing happened. Right, again, we'll come back to the latest episode. 2019, October, again I made a mistake. But this time, mistakes are, the patient walks in saying that I have bipolar doctor. So that's another thing. 2019, October, June 2020, still she is 80%. That is again 8 months. Look at this. Simple 2 months recovery, 2 months recovery. Here it took 8 months. Here again it took 8 months. The difference is, here I treated Escitalopram with valproate, lithium valproate, but here, if this diagnosis of bipolar spectrum or possible query bipolar disorder would not have been there, I would not have given risperidones and all those things. I would have treated the Escitalopram. This girl would have recovered. Again here, this girl would not have been on risperidone. She would have recovered. Again here, she would not have been on this quetiapine and then like a lithium for quite a length of time. She would have recovered. So now we understand the wrong overdiagnosis of bipolar disorder. It's not letting the patient's natural course of MDD recover on its own because of our works of art. This is my work of art. This is a classical example how we are disturbing this. Now you understand why you say that. I think last time I told that sometimes when I say that, now like the conceptually affordability, applicability, CBT has done some kind of problem for the management of MDD, but now I say that the concept of overdiagnosis of bipolar disorder and then over treatment of bipolar disorder, the concepts of lifelong mood stabilization are major reason why a simple MDD is not getting the correct proper treatment with antidepressant. That's doing more harm. This is an example. This case is an example. That's what my case last time I discussed with you. Now, all the time we are worried about non-efficacy but switch. This is the fact. This is the study, sir. This is 2018. Look at the 20-year period. What is the switch? Only in this group, when there is a family history, there is about 25%. This is over a period of 25 years. Over a period of 20 years, when there is a 25% switch, 75% of the people, you don't prescribe antidepressants because there is a switch. Because there is a switch. How can that continue? See, the rest of it, the inpatient and psychotic symptoms, all it is there, but for the sake of 10, last time also I told, for the sake of this 20%, 80% of the patients, that the kind of a fear has been created. I asked one group of students, postgraduate, bipolar depression, now what? No, antidepressant, no, why switch? Why? Hurry. With the family history, at the end of 20 years, there's a 25 switch. There's another study. That's one study. This is another study. It's in 2020 publication. Here, look at it. Unipolar depression. Inpatients, they say risk of like conversion is more 15 years. Here again, you see, what is this? This is bipolar disorder, right? Over a period of 15 years, the conversion from unipolar depression, which are hospitalized patients, it's only 8%. The other factor which is told is the inpatients, unipolar, psychotic, the risk is more. Again, the same thing, psychotic depression in this patient, 43,000 patients. The previous one, what I have shown is here is that this is 91,000 patients. Large number of patients. It's not a small numbers. 91,000, 20 years. This is about 43,000 and 15 years. In psychotic depression, again you see just 1% increase. Even the worst of cases you see with the family history, there's only 25% in 25 years. 20 years, 25%. For the sake of this, not giving antidepressants, I showed you, the long-term harm is something which makes me feel, am I doing right? Should not do harm to my patient because of the exaggerated perception of switch rather than non-efficacy. That's what the thing is. I think I have just 1 or 2 slides, and then I'm very happy that in the initial period, 90% of you told that episode is curable. Look at this. This is a nice simple slide. It's an MDD, major depressive disorder. This is MDD, long-term follow-up. There's a 2-year follow-up, 4-year follow-up, 6-year follow-up, right? Now let us look at 2-year follow-up. At the end of major depressive disorder, at the end of 2 years, 58% of they remain recovered. Recovered. No treatment, MD less than 7 in this 2 years. This is now like what the different shades represent. This is recovered. This is recurrent but without chronic. That means there's a recurrence of episode, but the episode is also brief. There is no chronic. Third trajectory is recurrent with chronic episodes. There's a recurrence, but at least one episode is chronic, not all. The fourth is consistently chronic. This is completely recovered at the end of the period. This is recovered with the recurrence, but the recurrence is again recovered. And this is recovered, recurrence, one of which is chronic. This is chronic. This is how these are. Let us look at this. 2 years, 58% are asymptomatic, less than HAM-D7. Absolutely no medicines, nothing. They're doing excellent. And if you add this also, another 20%, yes, they had a recurrence, but the recurrence episode is also recovered. It's not chronic. So at the end of 2 years, 78.8% of the patients with major depressive disorder remain either completely recovered or they had only one recovery in recurrence with again complete recovery. Which other psychiatric condition has this kind of? That is why I call it as a good prognosis. Child psychiatry, is there anything? Last time I was asking, is there any schizophrenia or any of those groups? Is there anything in the geriatric dementia which show this kind of a thing? Now, let us jump to 6 years. 2 years, let's jump to 6 years, 4 years, leave it. At the end of 6 years follow-up, MDD recovered. At the end of 6 years follow-up, even then, 33%, one third of them still remain recovered. That is, patients with MDD whom we have treated and recovered, 33% of them remain completely asymptomatic for the next 6 years. Fantastic. And then if you take this also, maybe they had some episodes, but again recovered. 66%, two-thirds, patients with MDD, you have treated, they recovered, 66% of them at the end of 6 years, either they are completely recovered or they had 1 or 2 episodes from which again they recovered. Absolutely excellent prognosis. Treat them properly. Diagnosis valid. Which other diagnosis have this kind of a validity? This itself shows that the symptom cluster, clinical course, with these 2 factors, it is satisfying. So, because you treat them effectively, treat them aggressively, treat them very well, this is the kind of benefit what the patient has. This is the kind of satisfaction what you have treating this patient. That's absolutely. This is why I'm saying that you have to treat them. There are 1,000 ifs and buts. MDD is not this, ADs are this are some things like in a powdered stone, and then this is suicidality. This is not antidepressant. This is should not treat by non-bipolar. Treat with psychotherapy. Another one point which I want you to understand is at the end of 2 years. Very very interesting point. I think initially we talked about, sir, MDD, when you talk about leave dysthymia, leave chronic MDD, I told. Here you see, this is a very interesting point. At the end of 2 years, 21% of MDD are chronic, consistently chronic. Sir, this is. When it came to 6 years, it's only 4.6% which is consistently chronic. What does it mean? Beautiful. 2 years, 21% are consistently chronic. 6 years, it's only 4%. That means even the so-called chronic are becoming recovered like this. Within 4 years itself, almost 12% have sort of recovered. They become not chronic. And then again, another 5% have become non-chronic, because this shows that at the end of 2 years, all this which you call as dysthymia, chronic MDD, and then resistant MDD, by 4 years, they are recovering. There's a small group of MDD where the course may be slightly prolonged, but still they recover. That is the beautiful finding of this particular graph. I think, once you see this, I think this is the, like a reference. Some of you can go back and then read the whole. Actually, the paper he has started with a different note, but this is the excellent findings. What I see this. 66% recovered or just episodes recovery, and the chronicity is only 4%, which is a surprise finding for me in this particular study, which beautifully shows that some patients may get prolonged more than 2 years, but still they are also recovering. So, sure, I think I've taken almost more than 1 hour this time. Sorry for that. So, what is that exactly? What do you do? So, this is what I say, that study, when somebody talks about it, don't talk about 1/3 being remission. Talk about the reason for attritions. Why the 4,000 patients, 3,000 patients have discontinued study. Step BD, when somebody talks about this antidepressants are not effective, ask them, these are the only 2 drugs. Other drugs are not shown in the step BD. When they talk about switch, I have shown you the slides. At the end of 20 years, 25% with the established family history only, otherwise the 8%. Why do you talk about switch? Talk to them about it. CBT. Now we come to the last 1 or 2 points. CBT. I don't know CBT, I don't practice much CBT, but CBT, even if somebody says that CBT is a cognitive behavior therapy, is an effective treatment in the management of major depressive disorder, I concede, but still, sir, I say that, what is the replicability of that? How many people are trained? How can you replicate that into the community? What is the affordability? My Escitalopram costs 10 rupees, 15 rupees. What is at least about 10 to 15 sessions of CBT is required. Each session, how much it costs? Where are the trained professional? How do we reach the last mile if CBT is taken as the? People talk We don't want medicines, we want CBT. Yes, sir. If you're a millionaire, I'll do it. If you're someone coming from a village, how do I do that? A treatment modality has to be effective, applicable, replicable, affordable, and accessible. Definitely. No doubt about it. ECT is very, very effective. But how do I carry it to the non-psychiatric clinics where MDD has to be treated? AD and suicidality. I have a request. If FDA can delete this, I think they have done a great service to humanity. Delete this. Enough, man. For 3 decades, you're keeping it black box warning. Even today, people can see that if you take antidepressants, the risk of suicidality increases, especially in adolescents. Adolescence is the period a parent brings his teenager to you for treatment. Is an MDD diagnosis. You start them on antidepressant, and the parent goes back and watches, looks at this Google, and he's terrified. Oh my God, my son, adolescence, is going to be suicide. Oh, I don't want doctor. Latency, you have to explain. Right. The reason why, I think it's getting 10, sorry, I'm sorry. The reason why I'm put Escitalopram, not SSRIs, is that SSRIs, again, there'll be questions. I don't want to have any questions. Escitalopram is a drug which is, I don't say sertraline is not useful. This is my choice, that's it. Escitalopram plus counseling, psychoeducation. This is the model which is effective in my opinion. Effectiveness is proven. This is applicable. Counseling, just a reassuring counseling, just once or twice psychoeducation. You don't have to come for 10 sessions. Escitalopram is 15 rupees per tablet, 10 to 20 milligram tablet. Replicable, anywhere it can be done. Affordable, as I told that. The only thing is accessibility to the last mile is something which is a big problem. Maybe telemedicine is going to help in this, but one of the biggest problems is that study what they talked about, attrition. My patients do not take antidepressants. When they do not take antidepressants, they will not get the relief. How do I make them take antidepressants? I have to make them antidepressant I have to make my patients take antidepressants. Means that first I have to tell them that antidepressants are effective drugs. Then I have to tell them that MDD is an effective, like a reasonably valid diagnosis. And they do not increase suicidality. That's why I listed all those things, 1, 2, 3, 4, what are the blocks? What are the barriers? I asked you, can somebody treat this like TB? I have taken a TB model. Tuberculosis DOT model, directly observed treatment application, medication complaints, caregiver administration. This is what I do in my clinic. Every single patient, I look at the caregiver and said that, Amma, please, you give the medicines. Patients are angry with me. Still, I say that, Amma, you give the medicine. This is TB. I compare management of like in a major depressive disorder, the clinical management, pharmacological management, something similar to tuberculosis, and I found some similarities also. Tuberculosis initially was thought to be because of bad air and then poor nutrition, all the things, they put them in sanatoriums. Here, psychological loss of loved object and then psychoanalytical theories and all those things, for a long time, it ruled the causation of MDD. Sanatoriums they were sent to. We have talked about psychoanalysis. Pharmacotherapy for tuberculosis started in 1950s. We had our first drug, like chlorpromazine in all 1950s. If most of you know that, the first drug, I think, what is that, iproniazide, which was actually supposed to be an anti-tuberculosis drug, which was marketed and prescribed as an anti-tuberculosis drug. I think it's in the New York State, Staten Island, and that sanatorium-like setting. They prescribed all those chronic tuberculosis patients this drug iproniazide. When they gave the drug, they found suddenly there's a lot of mood elevation. That's the first antidepressant. So there's a link between tuberculosis and depression. Varying presentations. Yeah, that's what. TB lungs, TB spine, TB abdomen, miliary tuberculosis is different. Completely different presentations, but anti-tuberculosis treatment works. So melancholia, atypical, psychotic, slightly different presentations, but antidepressants work. Latency, when you give antidepressant, at least it takes 3 weeks or 4 weeks before they see response. Even here, when you give anti-tuberculosis drugs, usually they say it takes about 3 months before they see that sputum negative. Then, even after sputum negative, 3 months, sputum becomes negative, but no, you have to take the patient medicine for the next 6 months. Patient asks, doctor, reports have come negative, but why do you have to take the treatment? No, you have to take the treatment. Here, I become all right, doctor. HAMD is less than 7. Why do you want me to continue medicine? No, 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 you have to continue medicine's continuation phase. So I found some similarities between these two, which some of you may feel ridiculous, but there is seem to be some sense in this. This is important. Anti-tuberculosis treatment, the drugs were effective, but there are a lot of failures. Then the WHO has come out with this directly observed treatment, which the Asha worker will go home every day and give the drugs to the patient directly. Dot. Phenomenal increase in the complaints and phenomenal increase in the recovery rates. I don't have this. Last time I presented, I'm almost like 40% to 80% jumped the recovery rates in tuberculosis, and the decrease in the so-called resistant like drug treatment is, it has improved significantly. I think we should do something like this. You have a diagnosis, correct, antidepressant. Only thing is patients don't take attrition for the antidepressant treatment. That is where directly absorbed treatment, directly administered by the caregiver, at least for 2 months. I feel that that phenomenally increases antidepressant response and then MDD. Or like in wishful thinking, my thinking, I don't know whether you share it with me, the dot reduces the mental health gap. Right, this is the last few points. Escitalopram, adequate dose, adequate duration. I think this is very, very important. Bipolar disorder, when they talk about giving antidepressants, you can give it at level 3 or level 4. Minimal dosage for a minimum length of time. It doesn't work, man. Minimal dosage, minimum length, it doesn't work. You have to give adequate dosage for adequate dosage, and then you say that it's not effective. That's what. Sometimes you may need a higher dose of it. This is something which we have to explain to the patient. This is something. There are a million misconceptions in the minds of, number one, lay public. Number two, all our non-psychiatric medical colleagues. And I don't know, some of our medical colleagues also share, psychiatric colleagues also share. I keep talking repeatedly. Escitalopram is a safe drug, man. It's a safe drug. Somebody asked me, doctor, if escitalopram is given and then somebody finds a sexual side effects, what do you do? Yes, that's a problem, but that's a temporary problem. Beyond that, nothing. So antidepressants are safe drugs, effective drugs. If this message can go into the community, among our psychiatrists, among the other non-psychiatric medical colleagues, I have to tell the physician, where do I see? There are hardly 7,000, 8,000 psychiatrists in India. There are 3 crore population. So the burden has to be shifted to the general practitioners, physicians. When I go and talk to a physician, when I go and talk to a general practitioner, I have to give them a model which they understand, pharmacotherapeutic model which is effective, which is replicable. I tell them you give escitalopram up to 20 milligrams. It's a safe drug. It doesn't produce any problem. At the most sexual side effect, nothing else, doctor. Go ahead and give it. Tell them that it takes about 3 weeks. Reassure the person. You go and tell them that ECT, they'll run away. You go and tell them that CBT, cognitive behavior therapy, 15 sessions, they don't understand. They said, I don't want to treat this fellow. So you go. We can't. Depression, MDD is a public health problem. You don't have enough resources to treat it. And talking about CBTs and then all the therapies which go on for umpteen number of years, and then there's, no, it's not going to work. Simpler model. Escitalopram for counseling, spend 2-3 minutes, explain to them, look man, this is a treatable disease, you'll become all right, give me 1 month's time, take 1 tablet, good. Don't dig into the family life and then love relationships and what is happening between wife and husband and then mother-in-law. It's none of our business. And then absolutely no business for the physician if you talk about it. So you have to give them this model and then see the mental health, that gap gets shortened. That is ultimately, that is what it is. This is what we look at. I look at symptomatic recovery in this. And the most important thing is every recovered patient from MDD is a brand ambassador for good prognosis of MDD, which right now psychiatry needs very, very badly. We need our patients to go and tell, yes, I did have the problem. I went to the doctor. He gave me 1 or 2 tablets, man. 2 months I became all right. That's it. For that, you have to Convince yourself about your diagnosis. Convince yourself about the effectiveness of it, and convince yourself about what are all the overdiagnosed, under treatment, and all those nonsense about antidepressants or not antidepressants, and this kind of a confusion. Have some clarity about why study showed this kind of results, why somebody talked about antidepressants or not antidepressants. CBT may be effective, but how is it replicable? ECT is excellent, very effective drug. Why the whole of West does not practice ECT? Why they have so much of race and depression? Why should we listen to them when they don't use as very effective therapeutic module? And a drug, wonderful drug like this, which is coming for 10 rupees. And maybe a counseling, maybe at the most, maybe one counseling, any of your psychologists or somebody who is like, just train them in a clinic. Do it. Do it. Cut down the attrition with of antidepressant medication with the dot. My opinion, these are some of the things where we can cut down that gap of management of major depressive disorder. This is to be done very effectively, but for that, psychiatrist himself have to reorient to the whole lot of a diagnostic or medication, the therapeutic equivalent, and then the effective model, and then only I see some hope. This is what my opinion. Once again, I think I took a very long time today, 1.5 hours. And then I told you that I'll not take questions. I'll go to the end till the questions. I don't know. Right, sir. Thank you very much. And this is something, medicine is approximate science. Let's not look at it as plus or yes or no, but then a lot of times we have to look at that. And then if there are there questions, right, there seem to be some questions, and then right, let me see if we can just talk a few of those things. Oh yeah, a lot of questions. See, I'll yeah, can before I answer the questions, can we run that opinion poll again?
Yes.
You can. Actually,
Yes.
I got a fantastic result, 90%. I don't need to go for it, but run it. Yeah.
So we are launching the first question. Just a minute.
I didn't actually get this question. Not made any dent in reducing despite all our treatments. How will our being brought for treatment explain difference in suicide rates? Yeah, right. So now I understood. Dr. Ishwaran, I understood that. No, it's a broad statement, sir. See, like he was talking about, it's very broadly saying that actually he also added that day, I'm just coming back from a press conference. Somebody asked me if the suicide rate in the community goes up, who should be hanged? And he told that jokingly, I said psychiatrists should be hanged. But then a lot of people say that, okay, no, suicidal, this thing, and then all those things are there. So, no, when he says that did not reduce it, it's a little bit of, trying to emphasize and then in the point. It's not that it has not reduced at all, but this is one component of it. But that is, he's not saying that we have not made any progress in psychiatry. No, it is not that. I don't mean that. Definitely it does mean that. But compared to the other ones, it is. So it's 80% gap.
So 92% have voted for yes.
That's great. 80% gap. I think maybe next time I'll come back here when we all meet sometime, one of you talking, and then I'm in the audience, maybe 1 year or 2 years later. If it can be coming to 75%, I'll be very happy.
The second question is on your screen. You can please vote.
Yeah, somebody asked like about antidepressants and then FDA black box warning. Does it have a cutoff age? Yes, they say that adolescents are prone, but I have showed you in the slide more than 40% of depressions have the age of onset in the adolescents. What are they talking about? That's it. It does all the damage. MD, see, like difference between MD. Oh, great. We have gone a little bit, almost touching 100. Thank you very much.
Yeah.
Thanks. Great. If you have time, some of you are willing to be with me. There are a few, maybe 5 more minutes. I think it's difference between MDD and MDE. No, no difference, sir. Major depressive episode. That episode is MDE. But suppose the episode is more recurrent depressive disorder. But the MDE as a part of RDD, MDE as part of bipolar depression, that's it, nothing else. It's the same. Should we treat all suicide attempters, even those with no underlying depressive illness, which is an impulsive attempt, for how long? This is a wonderful question. I'll do one thing. If there is a family history suggestive of any kind of a mood disorder, I'll straight away go ahead and then treat with antidepressants. If it is not, also I'll go ahead and treat with this, because, let me put it, sir. Most commonly, the so-called impulsive nature, we talk about borderline personality. Borderline personality has a MDD incidence of almost about 70 to 80%. So might as well it help. OCPD is another one where there's a lot of impulse. I see that. Again, I feel that SSRIs work. If it is a purely impulse control syndrome, emotional discontrol syndrome and all things, maybe I may not. But if the same question, when I was a student, if I was asked, I would have hesitated, because I didn't have a choice except tricyclics. Tricyclics, I am always afraid. But SSRIs, except paroxetine, 1 or 2 cases, there was no reported death, toxic, please correct me if any of you know, toxic overdoses of any of SSRIs, especially escitalopram, sertraline and fluoxetine, whatever may be the toxic over, single drug, combination drugs, it can happen. There is no fatality. When you have such a excellent drugs in the overdoses does not result in losing life, I would give it a try. I would definitely give it a try, but there I'll also look at my diagnosis and what are other factors. Yes, this is the same case I discussed last time. Irritability. Because of irritability as one of the diagnostic criteria, I made a wrong diagnosis of query bipolar disorder. Because I made a wrong diagnosis of query bipolar disorder, I was withholding antidepressants. Not only withholding antidepressants, prescribed the patient on risperidone. That is where depressive episode got prolonged for 8 months. Second time again 8 months. That is what happens, which we don't realize otherwise. Now, I didn't realize this only when I prepared the whole thing and reading the whole thing. Otherwise, patient comes and goes, you write and then you send, and that's it. Now, when you go back and look at the entire case follow-up, life chart you make, and you look at the specific periods, then it dawns, my God, this seems to be the reason. This seems to be the reason. Otherwise, no way for me to find out that particular finding. Now, that gives me a little insight how much of damage is happening. That's it. All people don't respond with antibiotics, but antidepressants, definitely SSRIs are revolutionary drugs. They're a great boon to the psychiatry and then patients with depression. That is why I told in the initial period, most of the antidepressants have come to us from the RCTs conducted by pharma. I salute pharma, whatever anybody says for that. They may be having some motives, but Escitalopram was a gift. Imipramine was a gift to psychiatric community from RCTs. There's no doubt about it. Role of ketamine, I don't have much of an experience. I have treated only one patient, bipolar depression was going on for a long time with ketamine, and she did not improve with that. One of this, my worry is, I am not against CBT, but I'm strongly talk against CBT for different reasons. Actually, I don't even know. I have not practiced, but theoretically, I'm not very favorable to cognitive behavior, all those things. But I talk sometimes a little bit more nastily about CBT. I talk very openly, sometimes rude. It sounds very rude. I feel bad about it also. But the reason is that you have a fracture. You go to an orthopedician. He does the treatment and sends for a physiotherapist, fine. You have a fracture, you go to the physiotherapist, that's a disaster. Your blood sugar is 400, you go to a diabetologist and you go to a nutritionist, fine, no problem. But at the 500 blood sugar, you go to a dietitian, it's a problem. CBT practice, people who practice CBT claim that drugs are useless, antidepressants are equal to powdered stone, lizard sperm, nothing more than that. And then you come to us, we treat you with now like in CBT without any side effects. That is the concept. I am against that. That when each of us go onto the stage and talk about it, I say that no. Put it as a supplement. Don't put it as a mainline therapy where people are having problems. I overdo, right? I agree. But that doesn't do much damage. You treat a patient with melancholia or psychotic depression with CBT, where are we going? That's a problem. I don't say that. Psychometry, it's again a controversial thing you have asked me. I have never had a great belief in psychometry as a valid diagnostic tool, but I do send for some kind of a backup work. I will never make a diagnosis of mine based on psychometry. It's like my blood sugar value. I make a diagnosis of like diabetes or a CT finding. I don't make. I don't make very little. How to determine adequate dose of exactly? It is like asking somebody how to know that what is the correct dose of metformin in the management of diabetes, what is the correct dose of atenolol in the management of hypertension. Correct, sir. We have to titrate, but there is some optimum dose. 20 milligrams is generally the optimum dose. 15 to 20. Some people may need 30, 40. Some people may do very well with 10, but that is the range. But if I give 2.5 and I'm afraid to give beyond 5, this is the problem, sir. This is the problem we have created for those poor physicians and general practitioners by not telling them clearly that this is a safe drug. They're dead scared to give more than 10 milligrams or 5 milligrams. So patients don't improve. Patients go to them. 30% of their patients are MDD patients. They do prescribe antidepressants, but adequate dosage for adequate duration, something is missing. That is where the problem comes. How to get ourselves trained in CBT? There are lots of CBTs, like people, psychologists who are trained, who train. CBT, I think, is demands as a center for CBT, and then they're doing great job, good work. Yes, right. Tolerability, not really so much. Not really. Escitalopram, I said that there is. Some people even in 5 milligrams complain of GI side effects. Give a little bit of pantoprazole or something. But broadly, 70-80% I said that they tolerate good. Placebo can recover time of etc. I could as well. If placebo of an SSRI can reduce the recovery time of a depressive episode, I could as well have the benefit of prescribing or any vitamin. Yeah, correct. That's what happens. But that shortening of the duration is something what I'm talking about. Anything, ultimately it may recur, but if you don't treat it early, there can be a possibility of continuing morbidity, developing other risks, suicidality risk, all those things can happen. Which condition paroxetine can be used? See, paroxetine, one thing, sir. In the guidelines, they say that bipolar depression, if at all you use SSRIs, except paroxetine, because step BD it did prove. The reason why I don't use paroxetine much is, number one, it produces a bit more sedation, which I don't want. Second most important thing is paroxetine is one drug which produces discontinuation syndrome. You know the reason why I don't use it? Majority of our patients' compliance is poor. Whatever may be the reason, like this COVID period, they go and stop my escitalopram or sertraline or fluoxetine, nothing much happens. Paroxetine, if they stop, significant discontinuation syndrome comes. You know what majority of the patients and relatives think? He got addicted to this drug. This is typically like alcohol withdrawal or the drug withdrawal. That's why you're having. That strengthens the belief in the lay public that discontinuation syndrome makes this addictive. That is why I don't use it much. Because I don't use it much, my experience with this is very less. I am extremely happy, sir, whoever you have told. Family history, family history, family history, family history, family history, and family history. We don't have CT scans, MRIs. Family history gives such a kind of a clue. It guides me. Past history, it guides me if there is a definite indication. But I think it's already 10:20. One last thing, family history, how it has become otherwise, I'll tell you now with this bipolar diagnosis. A patient is brought to you, an young boy, is about, let's say about 1920. He's brought by his father. This is case what's happening now. That's what is more, it's like literally flabbergasted. Patient is brought, you see him, and you see that, okay, right, and there's a lot of adjustment problems, mostly a personality, maybe a DMDD, or no, like borderline personality or OCPD. That's it. That's what is your diagnose. You make it and all those things. And finally, at the end of it, father says, "Doctor, I came to you 20 years back, 25 years back. You treated me. I became all right. And that's why I brought my son." Oh my God. I forgot about it. I am so old that 20 years back, 25 years back, father has come. Then I asked him, what? No, like, you came. I came that time, doctor, you gave some medicines. I became all right. I was taking the medicine for some time. I became all right. So I think a few people, they brought the prescription on. So I start there. I saw lithium or so-called valproate or antipsychotic. And some of them, intelligent people say that you made a diagnosis of bipolar. Oh my God, what is this? So now what's happening is family history, especially doctor, because you asked me, family history is important. I'm talking about the extreme part of it. Now, father's diagnosis bipolar disorder, so I'll be more tempted to make, I do it, son's diagnosis bipolar disorder. But now, with the change of my perspective and then my attitude in this so-called overdiagnosis and then personality disorders coming into that, now I asked the father, then make him sit and ask more details. Like how long you took, maybe a few months, there are some issues, doctor, some problem. Then I was all right, stopped medicine. Last 20 years, I was all right, there is no problem. Then was it a bipolar disorder? Did I make a wrong diagnosis of bipolar disorder? There is same thing which now I would have called as DMDD or a personality. That time my knowledge is that time that was a thing like somebody with this kind of a picture. So, sir, there are a few occasions where I have to go back and see that, oh, I think my diagnosis of bipolar disorder on this father was wrong. I don't think. So it has come to that. So, but this is one odd things only happens with this. But by family history and past episodes are excellent till you get your fMRI, DTI biomarkers. These are excellent clinical biomarkers. There is no doubt about it. Lithium, lamotrigine, how to choose? You can choose, sir. As I told that, after some time, I'm sorry, after some time, the depression has got natural course of recovery. Whether you give lamotrigine or lithium or whatever it is, in my opinion, I'm sorry, I'm trying to make it a little bit light. We can give any drug and it's going to recover. No doubt about it. But which one I would prefer? Maybe a lithium. But depending on, last time I was telling that if there are recurrent depressive episodes, I do give lamotrigine. The last point, somebody who said that except lithium, all mood stabilizers are right, sir. All of us will learn from our experience, and I think I should not be talking about so many things about it. I think that's it. We are done. We are done for the time also. It's 2 hours. Thank you very much. Thank you so much, especially this session. Actually, when I started, I told you I was a little bit nervous saying that what am I doing that putting my name and then will I be able to justify to my colleagues that there are serious concerns about the diagnosis of MDD, antidepressants, the management of MDD. People may say that, doctor, we all diagnose MDD routinely, we all give antidepressants, we all have patients who are recovering. What is the cribbing about all these things talking about? Like that, I was, like, and there are a lot of churning going on. But no, like, and I think it's reasonably, I think it's been good. And then, especially the very first opinion when you told me that episode is curable. It's actually such a pleasant surprise, sir, that was. Such a pleasant surprise. I'm happy. All of us think like that. Maybe thousand questions will come to you when you say that. What about functional recovery? What about this thing? What about remote? Right. I think maybe our Indian psychiatrists are much more practical, much more pragmatic, and then whatever may be the conditions, force more realistic rather than now like people in West, whom sometimes I call as armchair kind of a thing, which is happening. That is what I feel. Thank you very much. Thanks. It's a wonderful thing to be part of all of you. Thank you so much. Thanks, sir. Good night.
Thank you very much, sir. And sir, we look forward to having another enriching session coming Tuesday, that is 7th July.
Thank you, all of you there. And then let's see whether we can make some more sessions. And then I told you last time, maybe one of the sessions we'll have a placebo response where I think we can have a more interaction rather than, because nothing much for me to talk about it. Why do placebos have such a kind of a response? They play havoc. Why do placebos produce side effects? Why do placebos produce side effects? I don't know. Let's see, we can discuss. Thank you very much, sir. Thank you. Good night.
Thank you, sir. Thank you one and all for joining today. Have a great night. Thank you.